This week we're going to discuss tendon injuries, the most common types of tendon injuries, how they occur, and what risk factors are present with these injuries, and how we will mitigate pain or discomfort and treat these types of injuries in a season. So there's really no universal treatment for tendon injuries due to the vast array of modalities that are used for tendon injuries and treating them through sports med staff or with physical therapists or orthopedics. There's so many ways that we can treat them. There's really not a universal treatment that is said to be the most effective in mitigating pain or even repairing certain tendon injuries and change in structure of these tissues. So as we discussed in class, the Achilles and the patellar tendons are typically the most commonly injured tendons within athletes. Biceps tendon is also another big one for throwers. The plantar fascia can also be considered within the realm of tendinopathy. We know that plantar fasciitis happens a good bit. So this is also kind of a typical injury that can be considered within tendon injuries as well. Tennis elbow with the tendon on the lateral side of the elbow is often considered a common injury as well. So the common factor with all of these injuries is by and large load. So the actual load that is placed on these structures, especially with overuse, is going to be the culprit in actually causing damage to the tissue and ultimately causing some type of pain and discomfort. So typically with kicking athletes or lower extremity athletes, we have problems with the hip tendons and even the knee and the ankle. And obviously with throwing athletes, the most commonly injured joint with tendons is going to be the shoulder. Tendons play an essential role in the storage and the return of elastic energy during movement. We know that they can recoil at twice the speed of a muscle. So preloading a tendon through stretch means that the muscle tendon unit can actually propel the limb with a velocity and efficiency that is in far excess of isolated muscle eccentric concentric coupling, or what we have talked about as the stretch shortening cycle. So we know that incorporating that stretch shortening cycle with the muscle can obviously result in a greater force production with that muscle, but also preloading a tendon through stretch coupled with using the stretch shortening cycle within muscle tissue is actually going to be the most efficient and the most productive when it comes to moving our limbs. And you'll see this in the textbook, but it is estimated that using the elastic energy within the tendon reduces actually the metabolic cost of running around 30%. So not only does it allow for a better performance when it comes to athletic movement, it can also be much more efficient and allow our body to be at its best. So the more a tendon stretches for a given force, the more energy it will store. We know that with transferring force, stiffness is going to be a combination of the fibril type of the collagen as well as the cross-sectional area. So larger tendons should be able to transfer force in a little bit better manner. But you also have with stiffness and injury of a tendon, A more compliant tendon will strain more and store more energy when a force is applied to it, but a stiffer tendon will store less energy for a given force, but it's actually going to be able to transfer that force more quickly and is likely to also withstand a greater force before failure. Um, Overly compliant, or what we discuss as floppy tendons, might be at an increased injury risk because the relatively high levels of energy storage and strain. But an overly stiff tendon can also be at risk because of its reduced energy storage capacity. So fatigue and strain is associated with repeated and inefficient changes in the muscle fascicle length, and that might be a key factor in both actually tendinopathy as well as muscle strain injury. So when it comes to tendon function, we know that tendons adapt their structure according to the demands placed on them. So if there's a lot of demand or a lot of load placed on a tendon, cells known as tenocytes will actually conduct the process that produces collagen that makes up the tendon tissue. Tendons are also strain dependent, meaning that an increased tendon load will also increase tenocyte or productivity. So with this, though, there is a delayed hypertrophy, meaning that the production of collagen and the overall hypertrophy of a tendon does not occur instantly. So this cleanup operation of tendon tissue regeneration that happens when we have a high amount of load placed on these tendons can actually take around 2 to 3 days. So repeated sessions of high tendon load activities on the same day or even on consecutive days are likely to be destructive to our tendons. So the thing is, though, with high tendon load, it does vary greatly between and even within individuals. So it is very individualistic, and what can be considered high load for one person may not be considered high load for another. In the progression of tendinopathy actually represents a maladaptive response to overload, and a change in one or typically more than one risk factor can often be linked to the development of tendon pain. Now, we will go over a little bit of those risk factors in the next 2 slides. So, with tendinopathy, though, the pathology of this is often kind of unknown or sort of elusive, and so the symptoms can initially be mild, which often allows the athlete to continue to play, continue to train, and compete. So we know that insufficient loading has also been proposed as a potential cause of tendinopathy. We have this stress shielding theory of tendon breakdown, which means that portions of the tendon, such as the deep patellar tendon or even areas of the adductor origin where that muscle actually attaches, can become what's called deranged due to insufficient tensile load. So compression can also be a factor in tendon injury, particularly at attachment sites where tendon tissue might be kind of squished against structures such as the bone or bursa or some type of fat pad along the bone. So it can also happen when you have tendons that run alongside one another or even cross over each other. If you look at the Achilles tendon, particularly the plantaris muscle tendon runs alongside that Achilles, and can often cause compression and even what's called invagination, when that tendon actually flips over or twists on itself. So you can imagine the kind of discomfort and pain that could be associated with that. With this de Quervain's disease, this is primarily relative to the tendinosynovitis of the extensor pollicis longus and the abductor pollicis brevis tendons in the thumb and the hand. And tendinosynovitis is really when there's inflammation of the actual tendon sheath. So the tendon sheath is the really thin layer of connective tissue that actually surrounds the tendon. So if that gets inflamed, it can be very painful and cause a lot of discomfort. So these are two primary good examples of how compression and friction can actually cause some type of pathology and tendinopathy. Okay, so with risk factors, we have both extrinsic and intrinsic risk factors that can be attributed to tendinopathy. So we have our extrinsic factors here, our intrinsic factors here, and some examples of extrinsic could be the rapid change in training volume, the frequency, and even the intensity of training. Footwear is often a really big one, especially when it comes to the Achilles tendon or even the plantar fascia. Changes in footwear can often cause this problem, and it's something that we can actually pretty easily modify. Change in terrain is also another big one. If you go from running on asphalt or pavement to trail running, that can often cause some type of tendinopathy. And equipment change could also be a culprit when it comes to tendinopathy. If you think about tennis, if you change your grip size or something, that's going to change the way the hand actually performs when it comes to providing force to hold a racket or manipulate a racket. So that can also cause some tendinopathy as well. When it comes to intrinsic factors, age is obviously going to be a big one. If you think about youth athletes that grow really quickly, especially male athletes in their teenage years, if they grow, 6 to 8 inches in a year, that's actually going to be a major risk factor for tendinopathy, because their soft tissue, their muscles, and their connective tissue in their tendons may not actually be able to keep up very well with their skeletal growth. So that can cause some irritation as well. We see that a lot with patellar tendons because there's a significant amount of strain placed on them when they are elongated during that growth period. Body weight is also another large intrinsic risk factor. If someone is overweight or they have primarily an increased fat mass, that can produce a large amount of load placed on tendons that's not very necessary. And if you think about individuals that do have a good amount of fat mass, their load actually on their body is going to be placed differently. And if that fat mass is really placed in one area, it can actually change the way that your center of mass is distributed over your base of support. So that can also cause a problem and lead to tendinopathy of specific anatomical structures. We also have anatomical intrinsic risk factors, which means that sometimes, everyone is very different. I know that overall our bodies are very similar. However, if you have a small discrepancy in the attachment site of a tendon on a bone, that can actually significantly change the load placed on that tendon, especially during athletic movement, right? That tendon, if it's in a different area, it might have a different angle of pull, which can then cause some strain or inflammation in that tissue. Um, Genetics is also a big one. Um, Obviously, there's a genetic predisposition that could also be a factor in tendinopathy. This chart depicts musculoskeletal mobility and strength risk factors for common tendinopathies. I'm not going to go through all of these, but just to kind of highlight a couple of them. Plantar fascia for the first one. You could have limited mobility in your ankle dorsiflexion or even at your first met. Also, you might have some weakness in your tibialis posterior or your plantar flexors that might actually cause or predispose you to have a plantar fascia problem, which would obviously probably lead to plantar fasciitis. Another one is rotator cuff or the long head of the biceps tendon. A lot of throwers, especially with baseball, have what's called GERD, which is glenohumeral internal rotation deficit, which can also predispose someone to a tendinopathy problem. Excessive shoulder external rotation can also cause a biceps head inflammation in that tendon. So, these are some pretty specific changes or risk factors for certain musculoskeletal mobility issues. So if you look through these, you can get a better depiction of some more common actual anatomical structures that could be at risk for tendinopathy, and as well as the actual risk factor with limited or excessive mobility or weakness that can play a large role in these tendinopathies. So when it comes to diagnosing tendinopathy, it's really, ultimately, it's not that difficult to diagnose. These injuries tend to be characterized by well-localized pain and have more times than not, a distinctive gradual onset. So some common symptoms of that would be increased morning stiffness or decreased function. So if you see an athlete having a pretty significant reduction in running speed or jumping ability or even grip strength, you can probably pinpoint that they might have some type of tendinopathy issue. Diagnostic imaging can be helpful in diagnosing tendinopathy. The most useful kind of first line investigation with sports med staff is often the ultrasound scan. This is really commonly used within the diagnosing and even the treatment of tendinopathy. When it comes to MRIs, they can be occasionally helpful as a secondary modality, and it's really useful for providing high resolution images of deep tendons rather than superficial tendons. It can also give us a better idea of the exact location of tendon tears and ruptures, especially as it's associated with the actual joint and the bone. So typically we use ultrasound, but sometimes an MRI can be useful as well. So the cause of tendon pain can often be fairly elusive. So as we saw in the risk factor charts, there's a lot of things that can play into tendon pain. However, it's not always painful. So you can have asymptomatic instances where the athlete doesn't actually have any discomfort or pain until the tendon inflammation or tendon structure damage has gone into a significant stage that could be really detrimental to performance, and then at that point cause some pain. So Individuals that have suffered a complete tendon rupture often report that they had no preceding pain. Sometimes tissue abnormalities that are only seen on imaging can actually detect a potentially susceptible tendon and give us an idea of where this tendon pain is really coming from. So tendon structure damage or just the overall tendinopathy stages typically come in three stages: the reactive stage, the disrepair stage, and the degenerative stage. So within the reactive phase, the tenocyte activity is dramatically upregulated because it's attempting to actually respond to increased load by stiffening the tendon and laying in more collagen. Um, it can be persistent to intratendinous swelling, and that can begin to actually what's called cleave apart or disrupt that collagen framework. In the disrepair phase, where our tenocytes are actually trying very hard to keep up with further increases in load, um, there can actually be excessive demand that leads to areas of tissue breakdown. Within the degenerative phase, we see large-scale tenocyte death or apoptosis with major disorganization of that collagen framework. Um, Typically, this stage process is thought of as a continuum, but again, not every stage is going to be symptomatic. So, um, the stage of the tendinopathy is not it's not always going to be very clear based on symptoms alone. Also, the stage of tendinopathy is not necessarily consistent throughout an injured tendon, so you may have some degeneration at the tendon where it is very close to attaching to the muscle, but in the center of the tendon, that belly of the tendon, it may not be in that degenerative phase. It could be in the disrepair stage. So it's not always going to be consistent throughout the tendon, meaning there could be parts of a single tendon that are in different stages as compared to others. Um, and the stages themselves can actually overlap. So we may see, this overlap of disrepair and degeneration where you have really large scale tenocyte death, but you're still trying to keep up with load, and you see some significant tissue breakdown. So with the management of tendon pain, we have to first determine the most important factors that are contributing to the disorder, or and assess their relative contributions to the actual tendon pain and discomfort. Identifying and managing risk factors that are easily modifiable, such as footwear or equipment or load or the strength training program, can often be more rewarding and more effective than looking at the less modifiable risk factors, such as technique or any kind of mechanical deficiency, because having a significant change in mechanics can often take weeks or even months, whereas being able to change someone's footwear or their equipment to mitigate this pain and discomfort and actually reduce the progression of tendinopathy stages can be much more effective. Also, choosing exercises that will develop muscle strength and size without further overloading the tendon is really important. Um, Tendons need to be overloaded compared to their current capacity in order to trigger that collagen adaptation, but the overload really has to be controlled. So using slow and low impact loads, particularly in acute, proliferative stages, can be implemented to avoid aggravating the tendon and should be structured so that high tendon load only occurs every 3 to 4 days. So it's really important that structured training and exercise programs ensure that high tendon load days are fitted around these moderate or medium tendon loads days as well as low tendon load days. In looking at exercise prescription with tendinopathy management, there's not a cookie cutter recipe that will be effective and useful for all athletes or all people who present with some type of tendon pain. So, interestingly, heavy load exercise rehab is actually seen as the most effective or the most evidence-based tendinopathy management tool, but reactive and some compressive tendinopathies don't usually respond well to this heavy load application. And agreeing on time and commitment to complete a 3-month program with coaches and athletes can be really difficult. So with that though, it's known that heavy load is important, but again, we have to structure that around moderate and low tendon load days. So that's really where it gets difficult. Isometric loading, on the other hand, can provide crucial in-season mechanotransduction without the same susceptibility to provoke muscle and tendon pain. The frequency and the timing of isometric loading sessions is also really important to consider. So a maximum of 4 sessions per week with back-to-back days only occurring once is really important. And completing these isometric load sessions immediately after high tendon load activities or sport-specific activities, typically 24 to 48 hours before the next high tendon load activity is recommended so that you have time for adequate adaptation. So improving strength, control, and mobility of synergists is also very important and is likely to benefit or aid the affected tendon. With in-season tendon load management, creative conditioning strategies are really essential in maintaining musculotendinous and cardiovascular robustness, along with obtaining optimal weight if someone is not at their optimal weight for both the athlete sport and for their vulnerable tendon. So there are other ways to appropriately modify training strategies to save tendons, and that is via the 742 in-season training program. And this is where, on an average 7-day week, only a maximum of 4 competitions or actual training sessions that are relative to sport-specific tasks will actually occur. And only 2 of these will be back-to-back. So this would be if you completed or if you had a game on a Monday, and then you had another sport-specific task on Wednesday and Thursday, and then the following would be only Saturday. So you've got these break days in between to kind of relieve stress of that tendon. Also, completely offloading a severely reactive tendon can help a tendon settle more quickly or recover. And surgery is rarely required, but it should be considered when high quality conservative management is no longer effective. Also, typically surgery only is really needed when there is a rupture, obviously, or if there's an actual anatomical structure that is causing the tendon to be structurally damaged. So again, surgery is rare, but there are specific instances in which it might be necessary. When an athlete should return to play after recovering from a tendon um, injury, it really depends on the demands of the sport. So, if you have a really intense, high impact sport such as football, it may take a little bit longer for an athlete to safely be able to return to play without putting that athlete in a injury susceptible position. Um, Now, if you have a sport like cross country where the load itself is more relative to overuse, but there's no real high impact forces occurring on a specific tendon, they may be able to return a little bit quicker. Um, Gradual incorporation or introduction of accelerations, decelerations, and specifically changes in direction is really important. You obviously don't want to have an athlete who is recovering from a tendon injury just jump right into agility exercises in which they're changing direction a lot and they're really testing that viscoelasticity of that tissue where that rate of which load is applied is going to be really, really high. Also, when it comes to landing sports, you really have to progress from a controlled double leg jumping task to single leg so that you're not stressing that tendon even more and you're actually ensuring that the athlete can handle a dual leg support prior to looking at only single leg support. So that is the end of this lecture, and we will discuss more of this content as we go.